therapy is slightly different, which is actually completely different from chemotherapy. So today you will, let's see here, got it. Okay. So today these are the topics we'll talk about. We'll talk about what's cancer staging. You'll also meet the radiation oncology team. There's actually more than just the doctor when you get your radiation therapy. There's actually a whole team of therapists, dosimetrists, physicists, a lot of people who make sure that the treatment happens. And we'll also talk about what is radiation and how does it work, and how do radiation oncologists like myself design a radiation plan. And we'll also focus on some new therapies like SBRT for lung cancer, which is basically treating tumors with high doses of radiation. So the history of radiation oncology, patients were actually being treated with radiation for many years. The first patient was treated actually in 1896, so over 100 years ago. And doctors and non-doctors were using radiation to treat patients. And so some treatments were for cancer and some were for non-cancer conditions. So whenever we see a patient, the first thing we want to do is determine the stage of the cancer. Stage means the amount of cancer within the body. So certain breast cancers, they're very advanced, large in size. We do a CT scan of the whole body to see if there's any spread to the lung, the liver, any other parts of the body, because that affects how we treat the patient. If it's a patient who's stage 4, the cancer spread out, we may most likely start with chemotherapy, which is a systemic treatment. Chemotherapy is a drug that's either taken through the veins or through the mouth, but it treats the whole body, and it can cause side effects like nausea, vomiting, hair loss, and all that. Okay. Whereas there's also radiation, which is basically high-powered X-rays directed at certain local sites. So think of it as more focused treatment. And there's also surgery too, which is also a form of local therapy for a tumor. So the stage is very important because, for even lung cancer, the treatment between stage 1, stage 2, stage 3, stage 4 is completely different. And we also want to look at the patient's performance status. If the patient's too elderly or they have a lot of medical conditions, we may want to omit treatment because that may hurt them more than help them. So let's take a look at cancer staging. This is lung cancer staging. So the AJCC, every several years, usually about 5 years or so, that they update the staging guidelines. So in terms of the lung cancer, the primary tumor is how much tumor is within the thorax. So that's T for primary tumor. The next part is N for if any lymph nodes are involved, and M if there's any metastases. So let's take a look here. A TX tumor will be a tumor that can't be assessed. A T1 is a small tumor, usually 3 centimeters or less. T2 is a tumor usually 3 to 5 centimeters. And if it gets even bigger, then it's a T3 tumor. It's between 5 to 7 centimeters. And a T4 tumor is something that's greater than 7 centimeters. So that's pretty big. And also there's some other features too. If it's invading the heart, the trachea, the esophagus, or other structures, that is considered a T4 tumor. Here we also look at the N, as I mentioned earlier. N0 means no nodes are involved. N1 means some local lymph nodes are involved. N2 means the more advanced lymph nodes are involved. N3 means some lymph nodes on the other side, on the other lung are involved. So let's say it's a left-sided tumor. If the tumors are going over to the right side of the body, then that would be N3. And also M0 if there's no spread, and then M1 if there's any spread to other sides of the body. So we look at the different T, the N, the M, and then we get an overall stage grouping. So if you take a look at here, stage 1A encompasses all these different stages, T1, Mike, T1B, T1C. In the stage 1B, it would be a T2A and 0. So let's say you had a T3 N1 M0 tumor, then that tumor would be stage 3A. T3 meaning, like as I mentioned earlier, the size, N if any lymph nodes are involved, the close lymph nodes, and M if they're M1, then it's stage 4. So this is how we do this overall stage grouping. That's how we figure out exactly what the stage is. So that's very important. Almost every cancer has their own T and M staging. Some cancer is different; they have their own. But in general, it's all about like stage 1, 2, 3, 4. 1 being more confined, 2 being kind of bigger, 3 on its way to perhaps the lymph nodes, and stage 4 meaning it can cancer spread out. So when we treat with radiation, we have different purposes or intents. There's curative intent where we're actually trying to cure the tumor, and other times it's palliative, meaning we're just trying to relieve pain. A cancer may have traveled to the spine and it causes pain, so we give radiation to shrink it down, so to take away the pain. And some of these bone metastases are extremely painful. Patients tell me they're experiencing 20 out of 10 pain, just this horrible pain that's not responding to any medication. So usually the radiation is very effective in helping them to relieve their pain. So in the curative setting, if we look above, we treat definitively for prostate cancers, lung cancer, certain brain tumors like meningiomas. So with prostate cancer, less patients are getting surgery now, prostatectomy, to remove their prostate, because we have such good alternative treatments with excellent cure rates like radiation, where patients don't have leakage of urine like if they had surgery, and less chance of nerve damage. So that's in the definitive sense, where there's an intact tumor and we're treating it. We also treat in the adjuvant or preventative phase. So in breast cancer patients, traditionally women got a mastectomy, that their whole breast was removed. But then we found we can actually do a lumpectomy, just remove the lump of tumor with a clear margin, and then we clean it up with some radiation for about anywhere from 3 to 5 weeks of radiation to the area to help clean up the cells. And the chance of the cancer coming back looks like it's about the same as a mastectomy. So now women get to preserve their breasts. They don't have to remove their breasts. They get to keep the breast equal to the other side. So that's preventative. Same with brain metastases. Sometimes when there's a spread of tumor to the brain, surgeons go in, they remove the tumor, and then we provide some local radiation just to make sure we sterilize the area so the tumor doesn't come back. We do that for skin cancers, head and neck cancers, and even sarcomas. Sarcomas are muscle tumors. So if you have a muscle tumor here, it's removed, and we'll give radiation afterwards to help sterilize the area. And usually the radiation side effects are pretty mild. Radiation to like an arm would just probably be some redness, some itchiness of the skin, maybe some peeling. That's it. There wouldn't be any nausea. But if you're getting your stomach treated with radiation, yeah, you may get some nausea in the later phases of the treatment. And over to the right, pre-op. So sometimes we do radiation before surgery. Some certain tumors are too big or they need to be shrunk down in size before we can remove them. So as mentioned before, muscle tumors, sometimes they're so big, we radiate them first, get it to shrink, and the surgeon goes in and removes it. We also do that with lung tumors. And lung tumors, we actually combine it with chemotherapy and radiation to help shrink down the tumor before we can remove it. Because some of them are just so advanced. There's so many microscopic cancer cells in the area. Same with rectal tumors. Rectal tumors, by giving chemo and radiation before, or even afterwards, decreases the chance of the cancer coming back after surgery. And then that's important because these patients have gone through these big, debilitating surgeries. The worst thing is that for the cancer to come back, you then have to repeat the surgery, where sometimes it's not curable because the cancer is spread out. So by doing these preventative treatments up front, we help prevent any bad outcomes in the future. So let's meet the radiation oncology team who helps the patient in the office. So number one is the radiation oncologist. That's me. That's the doctor who oversees the radiation therapy treatment. So I design the radiation plan. I evaluate the patient stage and then make sure all that is finished. Design the radiation treatments, make sure they're safe. We do a lot of work with our physicists and our dosimetrists. They're the ones that actually help me design the plan to make sure it's safe. So what happens is, we do a CT scan. I get the images and I design the radiation plan. But I don't actually do all the math calculations. It's my physicist and my dosimetrist. In terms of delivering the treatment, it's actually delivered by radiation therapists. They're very highly trained in delivering the treatments for the patients. They help the patient get onto the machine. They help make sure the beam is focused to where the tumor is, and then they treat the patient. And once a week, I see all my patients to see if there's having any side effects, and I see the patients, with our nurse. So at City of Hope, we have our main campus in Duarte. They have several machines there, but we also have about 15 community radiation oncology sites. And each site has about, I would say, 1 or 2 doctors. And every single one has their own physics team, dosimetry, radiation therapy. So yeah, all 15 centers are all throughout Southern California, upwards from Santa Clarita, Mission Hills, and then I'm in the Glendale site. There's Pasadena, Antelope Valley, Corona. So there's a lot of sites throughout the Southern California region. So it takes a lot to coordinate care, but because we do it so often, we're able to do it in a very efficient manner. So what is radiation? Radiation is basically high-powered X-rays, and they can be delivered externally or internally. At Glendale, we specialize in the external radiation, which is the most common type of radiation that we see. So if you see in the top left, that that's a linear accelerator. That is what most people refer to as a radiation machine. And they range in cost. Most of these machines, when they were brand new, 10 years ago, they cost about, anywhere from $5 to $15 million per machine. So they're quite expensive. If you think about like the robot that they use for surgery, the Da Vinci, that's only about 1 million. So the radiation machines we use are much more expensive than even the most high-tech surgical equipment out there. So basically, it's high-powered X-rays that are directed, focused right onto the tumor. The other way is internal radiation, or also known as brachytherapy, where we can actually implant radioactive sources into the body. We do that for prostate. Sometimes, they implant about 100 radioactive seeds into the prostate. That treatment, if you go to the airport, you go through a metal detector, it's going to start lighting up. You're not going to be able to get through because it'll be able to detect the radiation that's giving off. But certain cases like head and neck cancers, if you've had chemo radiation and your cancer comes back in this head and neck area, now you can't get more radiation. So what happens is they can actually implant these needles into the neck, and they give off local radiation to treat the tumor that's come back. So there's lots of uses for brachytherapy, but in general, most 90% of patients are getting the external beam radiation. Only about 10% ever need internal radiation. So yeah, this is basically what type of radiation we use. So you'll hear a lot of different types of radiation: proton, photon, electron. The most common type is photon radiation. So at our Glendale site and at main campus, the machines are using photons, and these actually penetrate deeper within the body to help treat tumors, and they don't cause skin damage because they penetrate deep into the body. If we need radiation to treat the skin, then we use electrons, which is actually a positive or negative charge particle, and those don't actually penetrate the body as much. So certain skin cancers, we're likely to use electrons more than photons. This is a graph to kind of show you how deep these different types of radiations penetrate. So this kind of purplish one is a photon beam. It's 6 MV, so that's the energy level. So you kind of see when it goes into the body, it's about 60% dose. Within 2 or 3 centimeters, it's at 100% of its dose. And as it goes further through the body, it gets less and less dose as deeper it goes. Whereas electrons, this light green line, once it enters the body, it's a little bit higher. It's about 70, and then it kind of peaks within about 1 centimeter, and then it falls down very, very quickly. So electrons don't really penetrate the body that much. Okay, if you guys can see that. So this is the photon, it penetrates deeper, and this electron doesn't penetrate as deeply. So the way the radiation works is it's multiple beams that converge in the center and the center is where the hottest is. So if you look at this figure right here, this top part is actually the chest. This bottom part is the back. Um, the screen, the right side of the screen is actually the left side of the patient's body. And this is the other side. So these are the lungs, and you see these beams, they're actually focused from the front, the angles, and the tumors in the center. So that's where the center of the radiation doses are, right there. This is not as important. So yeah, this is what prostate brachytherapy is. So when they implant the radioactive seeds into the prostate, you take an x-ray, you can see all these seeds. You see that? See all these little dots right here? That's a radioactive seed in somebody's prostate. So this is, each one of these seeds is placed one by one. So this procedure can take over an hour, 2 hours, just to get in place. One of the scary things about doing this procedure is if you get into a blood vessel, one of these radioactive seeds can actually go to the lung. And now you have a radioactive seed in the lung giving off radiation. That's no fun. How does radiation work? So basically, the way radiation works is it damages the DNA of the cancer cell. The cancer cells now can't repair this DNA damage. So when they go to divide, they actually end up dying because they have all these the damaged DNA. But your normal cells can actually repair these DNA damages. So the way the radiation works, it preferentially kills off the cancer cell, but actually leaves your normal cells okay because your normal cells can repair that DNA damage. So radiation is given slowly. It's like getting a suntan. If you tan 20 minutes Monday, Tuesday, Wednesday, Thursday, Friday, then it's a nice even tan. But if you tan 100 minutes in a day, you can burn yourself. So that's why the radiation we give is given slowly over several weeks. So breast cancer patients, anywhere from 3 to 5 weeks. Prostate cancer is usually 8 to 9 weeks. Brain cancers are given over 5 to 6 weeks slowly. And that's not because we're trying to give a lot of radiation, we're trying to give it slowly so we can minimize side effects. So the DNA damages, there could be single and double strand breaks, and like I mentioned, the repairs happen within about 6 hours. And I talked about this also, how the radiation preferentially kills off cancer cells. Talked about this also. Yeah, and also with radiation, and also, getting 60 gray of radiation, it depends on how you get it. Was it given in 30 treatments? Or maybe it was given in 1 treatment? Because 60 gray of radiation given in 1 treatment is definitely stronger than if it's given up in small increments. So with radiation, if you take a look at this example, if we give 60 gray and each fraction was 2 gray, that's 30 fractions, 30 treatments, right? If it was given 6 times a week, 6 treatments a week versus just 5, the one that's getting 6 a week, that's going to have much stronger effects, side effects, because you're getting more radiation dose in a smaller amount of time. So that's one thing to pay attention to. Usually we do regular fractionation. I like to call it the slow tan, but there's also a new technology called radiosurgery or stereotactic body radiotherapy. We actually shoot large doses of radiation at a small tumor. And then we're able to do that because the target is small. So if the tumor is big, usually we say, hey, give it slowly, the radiation. There's going to be too much side effects. But if it's a small tumor, so sometimes there's brain tumors that the neurosurgeon can't get to, we can actually use radiosurgery to shoot these tumors and actually stop them from growing. And usually they can stop them growing permanently, so that patients don't even need surgery. So we talked about this. Talked about this also. Okay, so let's talk about how we design a radiation plan. The first step is to do a CT simulation and map out the body. So this is a CT scan. This is basically a map of a patient's body. See these 2 black areas? Those are the lungs. Okay, these are the lungs. And then here you can see the liver. This is the stomach. And see this blue on the top right? It's like a blue circle, and then there's a purple circle inside it. That's the radiation target. That's where the tumor is that we're targeting. So by using this CT scan, I can actually form a 3D map of the patient's body. All the radiation plans we generate are actually personalized to the patient's body. You know, some patients have a bigger tumor, so I need to open the fields more. Some people have a smaller tumor, I have to close the fields. Some people, their tumor is lower, some are higher. So with the CT scan, I can actually map out exactly where the tumor is and where we need to give the radiation to. Then at Glendale, we also have special 4D CT technology because lung tumors are moving, right? When we breathe, things move up and down. So if I only do the CT scan at one time point, it doesn't show me the full movement of the CT scan, right? So with a 4D CT, I can actually track the whole movement of the tumor up and down. So as you can see on the left, you can see it's just the red area that's lit up. But on figure C, look, see how everything is kind of, it's larger, looks like a hot dog. That's the whole, you know, trajectory of the movement of the tumor. So now when I treat, I know I have to treat that whole area. That way I don't miss the tumor. The other way around it, you know, that we did traditionally was just to add a margin above and below to make sure we catch it. But then we don't know exactly how much margin to give. Sometimes we give too much. And now we're giving too much lung radiation. So by using the 4D CT, we're really able to hone in on exactly where the tumor is and minimize side effects. So this is the planning of the radiation. So you see here in the red part, that's where the main tumor is. And the radiation beams are coming in from all these different angles. This is kind of like a map. This is, if you look at the right, you can see the different colors correspond to different doses. So the light blue is low dose. In the middle, you have green, then the higher, it's yellow, then red. So you can see how the dose is smeared out like that. The reason we do that is because you don't want one beam shooting all the dose. It's going to end up burning the skin. So by spreading it out, you actually make the radiation safer. And you know, we have set safeguard doses for every structure. We know the lung can take this much dose, the heart can take this much dose. So when we design the radiation plans, we make sure we're within those standards before we deliver the radiation. So that's how we can make sure the radiation is safe. And you know, these standards are based off years and years of studies, and you know, they're usually pretty exact. If anything, that they're a lot more conservative. You know, that way we can keep the patient safe. So this is a plan evaluation. After, you know, we design the plans, we look at these graphs. You know, I know it looks confusing with all these colors and everything, but basically we know a certain structure can get this much dose to a certain percent of its body. So, you know, let's take a look at this baby blue one, spinal canal or turquoise spinal canal. So we see, you know, about 20% of the dose is getting to about 10% of the volume. So, you know, we want these lines more to the left of the graph. That shows you're getting low dose. Anything to the right means it's getting high dose. So usually that's the tumor. We want the tumor to be like this big red line up here. So these are how we evaluate different radiation plans to see if they're safe. Because sometimes for a single patient, I may have my dosimetrist run 3 or 4 different plans, and then I pick out which one I think is the safest. Which one do I think is safest on the lung, the heart, and then that's how we you know, make sure we get a safe plan for the patient. So this is how the treatment is actually delivered. This is a machine, a linear accelerator. This particular machine, I believe, is about $15 million. This machine, you know, this machine, like most or all of our machines, you know, has image guidance on it. What image guidance is, you know, before every single treatment, we're actually able to take a mini X-ray to see internally to see where the tumor is. So even though we've designed the radiation plan, you know, to treat the certain area here, we also like to make sure we're lined up perfectly, that we're not over to the center or over to the other side. So by doing a mini CT scan, also known as a cone beam CT, we can visualize exactly where the tumor is and then treat. And that also makes our treatments a lot safer. So we do that commonly for prostate cancer. So in the past, they used to put these gold markers in the prostate, and then they take a few x-rays, and then the gold lights up, and then now you can see where the prostate is. But that's another procedure. That's having to put in gold markers through the rectum. There's always a risk of infection. But now by doing these mini x-rays, we can actually see internally, see exactly where the prostate is, and then align the beam to make sure the treatment's delivered right to the prostate. Sorry, that's my dog. The dog is whining. So where was I? Yeah, so basically, yeah, these machines, they're able to image and see exactly what the tumor is. All right, sorry. So side effects are generally related to the area that's treated. So with breast cancer, there's skin side effects, and usually the side effects don't happen right away. So, usually radiation is over 5 weeks. Each treatment is usually only about 5 to 10 minutes. Patients don't see anything, they don't feel anything. They're given Monday through Friday. Weekends they have off. So usually, over the course of the 5 weeks, the first 2 weeks, there's almost no side effects. Patients lie on the machine, they hear the machine making some noise, that's about it. The third week is when they'll start to get skin side effects like redness, itchiness, peeling, like a suntan, sunburn. And it gets worse and worse until the end of treatment. And everybody's body is different. Some patients at the end, they just get a little bit of redness. Some patients, they get a lot of peeling. So it really depends on the patient. But usually a week after the radiation, the side effects start to get better. And by 2 or 3 months after the radiation, the skin starts to look like the other side. You can't even tell the radiation was given. So in terms of the prostate's near the bladder and rectum. So usually the radiation is given over 9 weeks. So the first 3 weeks, there's no side effects. As they proceed, there's more bowel side effects. Pooping more, waking up more at night. So most patients, they notice that the number of times they go to the bathroom doubles. But after treatment, it goes back to normal. And when we treat like the brain, and there's more neurological side effects, patients can get sometimes headaches, nausea, vomiting. And same with the lung. When we treat lung tumors, patients can have cough, trouble swallowing, things like that. So yeah, the side effects are purely related to the area we treat. So sometimes patients, when they're getting radiation for the prostate, they say, "Oh, I have a sore throat. Is it from the radiation?" And it's not. The radiation is only in the prostate area. As mentioned before, side effects don't usually appear until middle of treatment, and usually by 1 to 2 months afterwards, the side effects are gone. So I wanted to finish the talk by talking about what are the newer technologies that we're using, which is called SBRT or SABR. Basically, this is basically just shooting high doses of radiation at a small target. Most of the research that's been done has actually been in lung cancer, and also a lot of in brain cancer too. And the reason we do it is, as mentioned earlier, that there can be small, deep brain tumors that are, maybe impossible to remove by neurosurgery. And if a patient is very elderly and very sick and can't undergo the surgery, then they have a tumor growing in their brain. So that's not okay to let it keep growing. We got to give them a therapy to stop it. So radiosurgery can be used in lieu of surgery, and we can get really, really good results. So this is a study looking at SBRT for lung cancer. They looked at 70 medically inoperable patients, and they were given about 60 degrees of radiation in 3 fractions. Okay, so usually if lung cancer is stage 3 and we're giving pre-op chemo radiation, it's 6 weeks of radiation given slowly over 6 weeks or 30 treatments. And usually we give about 60 grays. So this is actually giving 60 gray, that whole course in just 3 fractions. So that's big doses of radiation. And what they found was that the local control at 3 years, so 3 years later, it was 88%, close to 90%, they were able to control the tumor. And so that's really good. That's pretty much comparable to surgery. Surgery is 90-95% or above. So they found that the local control is really good. So there was a time where they were really only offering this treatment to older, frailer patients who couldn't have surgery. But now the results are so good that even patients who are actually fit, who can undergo the surgery, they still offer them SBRT instead because the results are so good. patients don't have to go through, the complications of a big surgery by removing a lung tumor. So based on the study, they found that, SBRT has really high rates of control in medically inoperable patients with stage 1 lung cancer. So more and more, we're seeing the usage of SBRT. We see it for pancreas tumors, brain tumors that have recurred. We're also using radiosurgery to target these areas. Okay, so that's it for my talk. Just wanted to see if there was any questions I could entertain.